Question 4. Which of the following hormonal changes is most directly involved in the pathogenesis of her menstrual dysfunction? Okay, so we got some menstrual dysfunction. Easy enough. It's a OB-GYN question. Next up, looking at the answer choices, a lot of hormones. It's all hormones. Okay, so this is an endo question. Endo, repro. Great. Easy. That's why I do this. It doesn't always help like that, but sometimes it does. So let's read through the stem and figure out what's going on. 20-year-old collegiate gymnast presents with persistent left shin pain for the past month. She skipped her last several periods, mentioned she hasn't menstruated in over a year. She's on a low-calorie diet that she started 16 months ago and now trains up to 4 hours daily. Her BMI is 16.5. Bone scan confirms tibial stress fracture. Vitals are within normal limits. And then there's a bunch of denies visual symptoms, heat, cold intolerance, or galactorrhea. So there's a lot going on here. Overarching theme is a very athletic young woman who is definitely, on BMI standards, anorexic. Now, which one of these? So the question is asking why, how does this contribute to her amenorrhea? Well, there is a very specific mechanism, but I won't discuss that yet. I want to talk about this as if I had no idea what was happening. How can we eliminate as many answer choices as possible? Let's start with A, increased insulin secretion. When do you see increased insulin secretion? I mean, obviously the most common cause is insulinoma. Obviously not. You could have an insulinoma or maybe type 2 diabetic or PCOS, somebody who is resistant to insulin or just has an insulin secreting tumor. She is probably not resistant to insulin. Actually, exercise increases your responsiveness to insulin. So I doubt she has increased insulin secretion. Decreased leptin levels. Okay, what is leptin? Leptin is the satiety hormone. Where is leptin secreted from? It's secreted from adipocytes. You think somebody with a BMI of 16.5 has a lot of adipocytes secreting a lot of leptin? Probably not. So right away, this is starting to make sense. Decreased leptin is probably accurate. The second question we need to ask ourselves is this a plausible cause of amenorrhea, right? Even if she has decreased leptin, if that doesn't actually cause amenorrhea, it's wrong. Well, let's say, I don't know. Okay, let's just say, assume we have no idea what's going on. Let's just come back to it. You don't have to eliminate something if you're not sure. Just come back to it. Elevated growth hormone secretion. Okay, I'm thinking frontal bossing, changes in her voice, a hat's not fitting, rings not fitting, shoes not fitting. Basically looks and sounds like Rocky Balboa. We don't have anything like that here. So that one just doesn't make sense. Increased thyroxine conversion to triiodothyronine. Okay, so in other words, T4 being converted to T3. Is she hyperthyroid? No heat or cold intolerance, so probably not with that alone. That's the only thing we have. Maybe I'm not totally sure, so let's just say, maybe. That's my maybe, a strike off. Next up, decreased prolactin production. Okay, so the mechanism is prolactin actually inhibits GnRH. So if she had less prolactin, she would have more GnRH, which means more estrogen, progesterone, and probably normal menstruation. So that's probably not it. We also say that there's no galactorrhea, meaning there's not too much prolactin, but they didn't say that there was not enough. Denies visual problems. I wonder if this is a hint at pituitary tumors compressing the optic chiasm. I wonder, as if I didn't write this question. So decreased prolactin production, probably not. Let's just say, I'm not really sure, but probably not. Elevated estrogen with low FSH levels. Okay, elevated estrogen. Well then, okay, how does she get a stress fracture? Tibial stress fractures. Think about that. Why do elderly women tend to break their hips every time they sneeze? Have you noticed that? It's because they're all osteoporotic. Why are they osteoporotic? Because postmenopausal women have a lot less estrogen, and estrogen is protective for bone. Estrogen, good for bone. So there's no way she has too much estrogen. Actually, no, that's a solid cross off for that one. No way. Okay, and then there was one. One where like, okay, I mean, this mechanism, this is true. Probably, she probably has less decreased leptin, but I don't know if it causes amenorrhea versus D and E where we're like, nah, probably not. Just pick this one, please. Do yourself a favor, just pick it. The exact mechanism is adipocytes secrete leptin when they're full. If you have someone who's anorexic, they are not going to have a lot of full adipocytes. They're going to have adipocytes that are not secreting leptin. Leptin is required for normal GnRH secretion. So now it's all coming together. If you don't have normal GnRH secretion, you're not going to have a normal estrogen, which means you're going to get stress fractures, which means you're going to have amenorrhea, not necessarily in that order. This is a common mechanism I do see tested occasionally. Not the most high yield thing, but this does definitely come up. So think female athlete, anorexic, low leptin equals low GnRH equals low estrogen, amenorrhea, and stress fractures.